As doctors, we've probably all had times when we've prescribed based on the advice of another health practitioner. Maybe you're a GP and you get a call from the district nurses asking you to prescribe antibiotics for a wound infection. Or you're a hospital doctor and you get a message saying that a patient who usually takes X medication at home is in the hospital and please can you prescribe it? Or you're a specialist and you're seeing a patient for another matter and they say, oh look, while I'm here doctor, can you just give me a repeat prescription of my other medications? I can't get in to see my GP. Or maybe you're working in a hospital team and you're asked to sign a standing order to allow the nurses in your team to provide a specific medication for patients without you seeing them. Or maybe you work in family planning and you're writing standing orders to allow other members of the team to provide medication when there's no doctor. Or maybe you're a telehealth doctor and you're writing scripts for patients who've seen a nurse-led telehealth service but who need medication prescribed. These are all, to varying degrees, what I would call proxy prescribing, where you are allowing someone else to use your prescribing rights or where you are prescribing based on information provided to you by someone else rather than as a result of your own clinical assessment. The situation with a hospital doctor providing a repeat script for patients in a clinic is slightly different, but I wanted to include it because I think it's a situation that many hospital doctors find themselves in, and I wanted to clarify their medicolegal obligations in that situation. So welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medical legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today, we're continuing our current series, which focuses on our risks around prescribing. And today we're looking at standing orders and also prescribing on the advice of another health provider. My name's Lucy Gibbard, and with me today I have my colleagues and fellow GPs and MPS advisors, Sam King and recently retired Tim Cookson. Hi, guys.
Hey, Lucy.
Hi, Lucy.
And we also are very lucky to have Kate Wills from our panel law firm, Wood & Kearney, who will help us with some of the legal aspects. Thanks, Kate.
Thanks, Lucy.
So let's start with the rules, because that's a good place to start. And we have looked at these in our two previous podcasts, but I think it's always worth having a look. And we're going to look at that Medical Council statement on good prescribing practice. It lays out what we need to do prior to prescribing, that we should be assessing the patient, determining that a medication is warranted, ensuring the patient is fully informed and consents to the treatment, considers the risks and benefits and keeping clear records. So they're telling us that we're doing that every time we write a prescription. I think we all know those rules, but the question is, do they still stand when we're actually prescribing on the advice of a nurse or based on a colleague's advice? Sam, what are your thoughts? You know, when district nurses ring you and ask you for antibiotics for a patient who's got a wound infection, can you do that? You know, the prescribing practice says we've got to see the patient, we've got to assess them, we've got to check that you're fully informed and consent to treatment. Am I happy just to prescribe based on a district nurse's suggestion?
Well, now that you've put it that way, Lucy, I'm beginning to question my own practice. Because in general, I trust a district nurse. Their bread and butter is looking at wound care. And when they tell me that a wound looks infected, I trust that they're correct in that. And often they do swabs whenever necessary. And so when I'm asked for a prescription for an antibiotic, then generally I will provide it. Now, that's based on the fact that obviously we have the clinical notes in our clinic, so I can see whether the patient's got allergies, the other medications they're on, and their problem list. So in that situation where I'm confident of the competence of the clinician asking me, and which is also related to the condition that they want me to prescribe for, then yes, I feel comfortable to prescribe in that situation.
And I think 99% of GPs do. You know, we are all doing it, aren't we? But when you read the statement, it's a little bit like,
it is.
Should we? But, you know, to make the system function, we are.
And yet the council also expects us to work in teams and to work collaboratively with our colleagues of various health professionals. So, and if we can't rely on them, then that's not working collaboratively with them. So,
But we do still have those obligations when we're prescribing to ensure all that those steps have been taken. And it is hard to know that they've been taken. But I agree, Sam, I do it. What about if it's not your patient, so you don't know them and you've never met them? Does that make a difference if it's a patient you've never met?
I do feel increasingly comfortable if I don't have any details in my practice because most of the patients are unknown to me. Yet I still have the clinical notes, the full record.
Yeah.
So, I've got that to rely on. If you didn't have that, then I think you'd be a little cautious.
What do you think, Kate? Do you think that's a reasonable thing for doctors to be prescribing based on a nurse's recommendation?
I think in the example that you provided with the wound care, the district nurses, that sounds perfectly reasonable. You would need to justify and be clear in your own mind that it's reasonable reliance. And that means understanding the capabilities and competencies of the person who you're receiving that information from. And it could require you to ask more probing questions about what have you asked the patient, those sorts of things.
The problem is often it is literally just a message. The district nurse has rung, Mrs. So-and-so's got a wound infection. Please can you prescribe some antibiotics?
Yeah, in rest homes, they will often send a photo. And that's really helpful.
Yeah.
And often, you're the contracted GP or your patient's been there a long time and so you've got an idea of the competence of the staff there. But the photos really do help, obviously. And it's probably a closer relationship that we would have with the staff in rest homes as opposed to district nurses. I don't know any of the district nurses by name, never met them, whereas in a rest home, you'll know them because you've seen them a lot. And so I guess it depends on the circumstances and what you're being asked to prescribe.
So, Tim, how about if it's another doctor? We sometimes prescribe for another doctor who's got prescribing rights themselves, but there may be some reason, maybe they haven't got fellowship of the college and they can't get special authority funding for a particular medication or something like that. So one of the registrars comes along and says, oh, can you just write this script for me? I've seen this patient, they need X.
Yes, I think bottom line is it's reasonable to do that, provided you've taken all the right precautions. So you've followed the instructions under the council guidance, which is that you've assured yourself that, yes, the medication is warranted for that patient's condition, that they don't have contraindications to what you're about to prescribe. If it's a medication that could have significance for example, someone who's pregnant, then making sure that contraception has been talked about.
So the doctor who does the script, all that lies on them, not the doctor that asked them.
Before writing the script, I think that doctor who prescribes it has to be sure about those things. So if that information is not provided by the first doctor, I think the doctor who's being asked to prescribe should write back and say, look, I need more information to be able to write that prescription.
I think it's
otherwise they're vulnerable.
It's reasonable for a young GP or a GP registrar to go to a senior colleague who's a fellow and says, this is the history, these are my examination findings, I need your advice. And for the senior doctor to give that advice and the junior doctor to take that advice in the same way that I might ring the hospital and speak to the general surgical registrar or surgeon on call, get advice. I will document that and I will follow it. And, if he gave the wrong advice, I would expect that through the HDC, he's accountable for that advice that I have followed. And I think, a junior registrar...
Prescribing is a slightly different thing, though, when you're saying, and now it's a step beyond giving advice, when you're then putting your signature on the script.
So the GP registrar signs the prescription?
No, they're asking the fellow to sign the script.
Oh, to sign the script. Yes.
It is a step beyond.
It is a step beyond. Sorry, I thought it was just advice you were asking for. No. You're absolutely right. If you're prescribing, if you sign it, it's all yours.
If you sign it, it's all yours. I think that's the bottom line.
What about the scenario where, say, for example, you've got a patient with a really complicated urinary tract infection, or maybe a prostatitis, with very few medications that will actually be effective. So you ring the local specialist and they suggest prescribing an antibiotic for which needs a specialist authority, but you've never prescribed that antibiotic before. So you have no knowledge of it. If you're going to sign that prescription, you may get some information from the specialist, but that's kind of a tricky scenario for the doctor. I think
because that's reasonably common, isn't it? That they name some antibiotic, you think, gosh, what's that? But when that happens for me, I personally go into NZF and read through contraindications, monitoring requirements, all those kind of things, because when I'm signing it, I'm responsible for it. And even if they've recommended that it's the right thing, I've still got to check all that stuff on NZF because I just don't know the drug very well. So I think you do.
I think that the medical council have that expectation.
Yeah.
That you still ensure that you believe that it's the right drug, right patient, right dose, all those sorts of things. In the situation, for example, where I might have called a psychiatrist and to ask for advice about medication, there have been occasions where they say to me, you should prescribe this dose. And I'm like, that sounds like a very big dose to me.
Yeah.
And my hesitation is that I will be signing that script. And so often I will double check, is this the dose that you recommend? Is it safe to provide this for my patient? Because I want to be certain, and I will certainly document that as well.
Yeah, I think that's all very sensible. Mm-hmm. One of the other things, under the medicines regulations, it says that no doctor is permitted to prescribe prescription medicine to an individual unless it is for the treatment of a patient under his or her care. So, Kate, this is always an interesting thing. What criteria would you consider need to be fulfilled for a patient to be considered to be under the doctor's care?
I hunted pretty hard to find an answer to this question, which is interesting because you would think it would be easier and should be easier to find. There's no definition of under the care of in the legislation itself, and it's that sort of concept's not clarified or explained in the council's statement on good prescribing. The only place I could find where the point had been considered was in a very, quite old High Court judgment back in 2004 that involved a doctor signing off prescriptions for patients who had purchased the prescription medication on the internet. Mm. So it was confirmed in that case that it is not necessary in every case for a doctor to see a patient face-to-face before issuing a prescription for that patient, but that the minimum requirements of under the care in Regulation 39 would be that, 1, some information be given about the patient to the doctor, 2, the patient acknowledges the doctor is his or her medical advisor for this purpose, and 3, the doctor accepts responsibility for treating the patient for the condition referred to. So in that particular case, there was no consults or calls between the doctor and these people that received the scripts, but the patients did provide information about themselves in internet forms, and they acknowledged that they were to be treated by Dr. R with the medications that they sought to purchase, and that was sufficient to be deemed under his care for the purpose of Section 39. Since 2004, this case, I can't see their point has come up again in the courts. The PDT has considered on a couple of occasions whether Regulation 39 has been breached or not. I found a case where a doctor had been prescribing medications in the name of patients without their knowledge and with an intention that the medications would be to stop the practice as opposed to ever be needed by the patient.
Might be a little common, that practice.
Quite common. There's a few cases about that. And in that situation, obviously, those 3 requirements to be under the care of weren't met because the patient didn't acknowledge that the doctor
was providing that service to them
for the purpose of their own health.
It's hard because I think for telehealth, under the care of, I think when you see a patient in a telehealth consult, that's absolutely clear that at that point you've had a consultation, they're under your care to give a script. I think some of the other services which, that where a doctor is prescribing for a patient they haven't had a contact with, you have got to be a little bit careful. I think, is this patient under my care? Do they acknowledge that I'm the person prescribing this? It's a bit different if you're in a practice and you're prescribing for a colleague who's on holiday who isn't available that day, where you've got the notes and everything. And I think it is such common practice that you prescribe within your practice as that if they're registered with a practice, they're under your care. I think that's reasonable. I just think that there's some situations now with telehealth where it's less clear that a patient is under the doctor's care. And, it will be interesting. We actually talked to the medical council about this, but we haven't really had a clear clarification as to what this actually would mean in the context of some of the telehealth systems.
But that case is really interesting, that judgment, isn't it? Because it does definitely allow for a single episode, a single prescription to be regarded as being under the care of that single episode and that single purpose. And you're right, Lucy, there may be some other things that need to be there, particularly in the telehealth kind of scenario. But if they meet those requirements of the that laid out by the judge, then you'd have to say that ought to carry significant weight if it came to an HDC complaint.
Interesting. The other issue in the medical council statement, which I think we should highlight in this context, is where it says, before prescribing any medication for the first time to a patient, council expects you to have a consultation with the patient. If a consultation is not possible because of exceptional circumstances, discuss the patient's treatment with another New Zealand registered health practitioner who can verify the patient's history and identity. If you're providing locum cover for an absent colleague or discharging a patient from hospital, you should review the notes before prescribing. So look, that when the council says prescribing for the first time, it's one of the things that always gets me. Do they mean it's the first time that this particular patient has had this particular medication? Or do they mean that it's a new patient to you and you haven't prescribed this medication for them previously?
Or do they mean it's the first time you've ever prescribed that particular medication?
Yeah. Okay. Yeah. Anyway,
so three options. Which of those three?
What is first time?
Let's toss the three-sided coin.
What does prescribing any medication for the first time to a patient? What are we interpreting that as meaning?
To me, that means it's the first time the patient has had this medication. There's a lot of comfort when a patient says to you, yes, I was on this SSRI 2 years ago and I'd like to go back on it, because then the patient's got experience with it, will have had hopefully the risks and benefits explained, and the fact that they're wanting it again was an indication that they were very, very happy with it and didn't have any problems. So that would be my interpretation.
So you think the first time thing relates to that specific patient with that specific medication?
Yes. Kate.
Just to complicate things, I wondered whether it's the first time you've ever seen the patient, regardless of the medication, because that second sentence, verify the patient's medical history and identity. If you're verifying someone's identity, it kind of tells me that you haven't seen them before, and it's important to make sure you're talking to.
So is it before prescribing any medication for the first time to a patient?
First consult you've ever had with this patient.
Right.
Is how I read it.
Is that how you read it?
Hang on, but doesn't it say if a consultation is not possible, then discuss, then
but that implies that either you're having a consultation or it does
Sorry, if you're not having a consultation, you need to verify the patient's medical history and identity, because you're not actually in a consultation with them. Is that not how it reads?
I think the answer is it's really hard to know exactly what they mean. Do you agree that it's not clear whether it's the first time this patient has had this medication or it's the first time that you are prescribing this medication to this patient?
But I suspect that the intent is that if it's a new medication for the patient, then these things apply.
So it's not that when the patient is new to you.
No.
Are there ever any medications that are so sort of low level that you could just prescribe them without? I'm trying to think of an example. I wonder if I called our doctor up and said, can I have Pamol suppositories for my daughter? Would they need to see Adeline, my daughter, for that?
I don't think any GP would say make an appointment.
Yeah.
Not for something along those lines that you can pretty much buy over the counter.
So that sort of led me to think...
that is medication for the first time.
Exactly. That sort of led me to think maybe it does mean meeting the patient for the first time, because there are examples where there might be situations where it's okay to prescribe a medication without seeing the patient.
Well, if you think about common practice then, common practice would be that no. How often do we get asked, oh, this child's come and they've had their IMS, they need some paracetamol. I'd prescribe it without too much thought. And I think waiting rooms would be clogged, appointments would would be blown out if we had to see every child or any patient who is asking for some kind of medication along those lines.
But it would be very common if a patient rings up and says, I want this medication, and they've never had it before, you'd say you need a consultation.
Of course, if they've never had it before.
Yeah, I think it's a tricky thing, because I think it is mostly taken as the first time for the patient. I think that's how most people actually interpret that, rather than the first time of the doctor having anything to do with the patient. But it's hard to say. And look, here are we all discussing it, so it's obviously not clear. And again, it's a thing that we haven't had clarified.
Yes, it's interesting to me that if it was as straightforward as I believe it is anyway, that council haven't clarified that. So that in itself makes me consider that maybe it's more complicated.
But the important thing is, as far as when we're prescribing on others' advice, is if that passage means for the first time of the doctor knowing them or having anything to do with this patient, is that then only allowed in exceptional circumstances, because there's no consultation there? And that passage means that you're only allowed to do this in exceptional circumstances without a consultation. And then you think of all the times you're doing the district nurse prescribing, and that's not really that exceptional. So
they talk about if you're providing cover for an absent colleague, that so long as you review the patient notes.
Yes,
so you've got.
But I'm talking
information
about prescribing on the basis of somebody else's another health professional's advice. The district nurse ringing you and saying, "Can we have some antibiotics for this patient?" So there's no consultation, and it's the first time this patient has been given erythromycin.
Yeah, but that's what this statement, the way my read of it is that's what this statement is referring to. Because it's saying before you prescribe any medication, ... if you're providing locum cover for an absent colleague, you should review the patient notes before issuing any prescription.
But that's not a locum cover if you're doing it at the advice of a so I'm their normal GP.
No, sorry, I thought that what we're discussing is prescribing any medicine for the first time for a patient, but you're extending that to on the request of another.
Yes, well, that's what I'm saying, is if we're doing something on the request of another, can we do it?
Yeah, does that qualify as exceptional circumstances?
Does that
to
qualify
not have
as
your
exceptional
own
circumstances?
It's the only way to weasel our way out of this would be to rely on the fact that exceptional circumstances isn't exhaustively defined in the council statement. They provide some examples that exceptional circumstances can include an urgent clinical situation or unavailability of a doctor. We could say, or other things. We're allowed to try and squeeze other reasons into qualifying exceptional circumstances. It's a risk, though, because we don't know if those will be accepted or not. But that's all we can do, I think, to try and justify that.
And the problem is we justify it also by saying it's usual practice.
Yeah.
So on one side it's usual practice, and on the other side it's exceptional.
Yeah.
And in these situations, there has been a consultation. It's just that you personally haven't done it. But it's been done by a health professional like the district nurse or the telehealth nurse or whoever. So the consultation has happened.
But it says the council expects you to have a consultation.
Yes. So maybe the wording could be altered slightly, and that would make it easier.
I mean, there's a situation where we have had questions about whether in a telehealth service that's run by nurses for low-grade issues, UTIs, respiratory tract infections, things like that, where the nurse does the telehealth consult and then the notes are provided to the doctor to prescribe based on the nurse's advice. Maybe this patient needs, nitrofurantoin or something for their urine infection, has access to the notes and the nurse's assessment but hasn't seen the patient, whether that is considered appropriate.
I think it has to be considered appropriate because it is standard practice, and so long as the prescriber is satisfied that they have all the relevant information that they would have gathered if they'd had that consultation. So the patient doesn't have a high fever, they're not allergic to it, and the condition appears to be a UTI. Yeah, I think it's fine.
I wonder ultimately whether it would be best if council could clarify what they mean in their statement. I mean, if you think about the rapidly changing environment that we work in, we've got multiple different team members now in primary care, don't we? Of all different shades, if you like. And it becomes more and more common that patients are being seen only by somebody else and not the prescriber. And from a practical perspective, that can't happen unless we're permitted to do so under these statements.
I mean, that is the problem. That the council statement is quite prescriptive, and it kind of reflects general practice as it probably was 40 years ago.
Or even
but it
10
doesn't
years ago.
actually really reflect the current health environment where doctors are working in teams and assessments are done by others, and the doctor's ability to prescribe is used by other team members. So, Tim, do you think it would be safer for doctors to get their nurses to do nurse prescribing qualifications and then the nurses prescribe them themselves? You know, in the situation now, we're talking about the changing teams environment, but actually the other change is that there's courses that nurses go on to become nurse prescribers. Is that a safer option?
Well, certainly it would take away all vulnerability from the doctor for any of those prescriptions. And yes, you'd have to rely on the qualification process for the nurses that they then do become sufficiently competent to prescribe those medications. Of course, it's a relatively limited list that they're able to prescribe, and that's clearly been looked at carefully to ensure that there's not excessive risks for patients. So, it's a great move.
Yeah, I think it's probably the safest way forward. Currently, with the statement from the Medical Council as it is, I think there are some vulnerabilities created by the way we're working at the moment. So, Kate, we then come on to the issue of documentation. Thinking about the situation where you're prescribing on the advice of another person within your same organisation who's seen the patient, is it okay for the doctor just to then write the script as they've been asked to do? Or should they actually go and write in the notes to clarify that they have reviewed the notes and the allergies and record that what they understand about what they've been told? You know, is there an onus on the doctor to write notes as well? Or are they allowed to just say, I've read your notes, here's the script?
The practitioner writing the script will have the ultimate responsibility for the prescribing, and so there absolutely should be a good record of the information on which the decision to prescribe was made by the doctor. And I would think that should include their knowledge of the history, relevant clinical findings or results of tests, what the practitioner understands of information given to and options discussed with the patient. The reason or clinical rationale for the script should also be noted by the doctor, as well as any required follow-up. And that's quite a prescriptive list, and it's prescriptive because it's set out in the council statement on managing patient records. That is the information that needs to be recorded in the clinical notes. I would suggest too that if relevant, the practitioner should confirm the patient has been advised, counselled in respect of any risks or potential adverse reactions, and record that that confirmation has been received.
So can that be done by the clinician who's been seeing the patient, or does the doctor doing the prescribing have to write that in the notes separately?
Well, I expect the person who undertakes the consultation probably has an obligation to record that to record that themselves too. Right. But that information is sort of important to determining whether the prescription is appropriate. And so I would think the doctor who has responsibility for that prescription should confirm in the notes that he or she understands that they have been given this information.
It's hard, though, to see how the doctor will know that the patient has been advised about adverse effects, alternative options, all those, and what those alternatives. Even if the person who saw the patient has written in the notes advisory alternative options, but how does the doctor know what alternative options and whether they were the appropriate? You know, it's really tricky.
I think when you're talking about someone who hasn't got prescribing rights, asking you to prescribe, it's a little different from another doctor asking you to prescribe. And, when you think about supervision requirements or appropriate supervision of other clinicians who aren't regulated, for example, you do need to ensure that they are competent. And so if you're all working as part of a team, you would hope that you have a good idea about the competence of that clinician, about their familiarity with that particular condition that they've seen the patient about. So you've got some background. It's not just doing it blind. You're not just prescribing blind. Does that make sense? Because you think about the practicality of what Kate is suggesting. In an ideal world, of course, we'd have the whole consultation ourselves, wouldn't we? And we'd go through and document all these things. But in practice, it's just not workable in terms of timeframes. And I would suggest that for clinicians in the situation where it's someone within your team that you work with, that you've got some kind of background knowledge of the competence of that particular clinician. And that, I think, will save you time. And plus a policy. So, if a nurse has seen a patient, then my expectation is that you will provide this information around that antibiotic or that medication.
Or policy that in your own records, district nurse or whoever it is, you need to write, have discussed adverse consequences, these are X.
So I guess the question is whether the doctor can delegate safely that task about informed consent to that, to the nurse or to the ECP.
And that is the problem. Can the doctor say, I know this ECP, I know this PA, I had a reasonable belief that they had gone through the information with the patient, including adverse effects and allergies. I was prescribing based on that understanding. Therefore I'm all right. Or is the medical council going to turn around and say, no, you wrote the script, you're responsible? That's a line in the sand. You can't say that you relied on somebody else to do that.
In the same way that we think about standing orders, the onus is on the person who signs the standing order to ensure the competence of the clinician, that they understand the condition, the medication, the indications, all of those sorts of things, and have done all of that. There is an expectation that you've signed that off. And if you think about supervision, that if you've signed them off, you've checked it, you've audited, and you've confirmed that they are competent to talk about UTIs, for example, because you're really only talking about a limited number of conditions, generally speaking. Except maybe with PAs, I think that's maybe a little bit different, but generally speaking, it's for a limited number of conditions. Then I would have thought, in fact, you'd have a reasonably robust system in place. I personally wouldn't have any concerns about signing a prescription under those circumstances.
And the statement does say that, if you prescribe at the recommendation of another New Zealand registered health practitioner who doesn't have prescribing rights, so they're clearly acknowledging that we do that. You must be satisfied that the prescription is appropriate for the patient concerned and that the health practitioner is competent to have recommended the treatment. So they are laying out a system saying you are likely to be doing this. It suggests we can prescribe on the advice of others.
I think that there's two bits to satisfy in that sentence, right? So I don't think you can I don't think if you satisfy yourself that the person you're dealing with is competent, that you're out of it and you've ticked your box and nothing can come your way. It says first you must be satisfied that the prescription is appropriate and, or whatever the wording is, it's and, I believe, you must assure yourself of the competency.
Yeah.
So at the end of the day, it is your script, you're responsible. Of course, if the person you're engaging with is a senior clinician who you know very well, your reliance on them simply telling you what they told the patient or your understanding of what they would have told the patient based on your knowledge of their experience would be perfectly reasonable to rely on. And so I think it's the reasonable, that the competency question feeds into the reasonable reliance point. If you're dealing with someone that's maybe not so experienced, you've got a bigger obligation on you to satisfy yourself that the prescribing is appropriate to ask more questions.
And of course, the person may be competent in some areas, but not in others. So, you might have a health practitioner who doesn't have much psychiatric experience, and you know that, but who's recommending some complicated psychiatric medication for your patient and asking you to write a prescription. You might say, okay, well, maybe they do have that condition, but actually I'm not sure of the competence of that person to recognise and understand that condition fully, to be able to satisfy those conditions.
Okay, so we've covered a lot today, and I really don't think we're going to have time to do standing orders today, so we might push that off into our next episode. But thank you for listening to this podcast, and I hope it's been helpful. And thank you to Tim and Sam and Kate for joining me. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave us a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org.